On March 23, 2010, President Barack Obama signed the Patient Protection and Affordable Care Act, commonly known as the ACA or Obamacare, into law. At the time, the ACA was the most comprehensive and expansive healthcare legislation passed in the United States since the Social Security Amendments, Medicare and Medicaid, of 1965. Despite its significant impact on the American healthcare system, many Americans today lack a solid understanding of what the ACA entails and the historical context that led to its passing. According to the Kaiser Family Foundation, an independent health policy research group, only about 4 in 10 Americans are aware that the ACA prohibits insurance companies from denying coverage based on pre-existing conditions. Arguably, one of the law's most widely covered and advertised aspects by mainstream news outlets. Given that healthcare is currently the third most important issue to voters in the United States, it is critical for public discourse to examine this subject in greater detail. So in this video, we will discuss the following questions. What is the historical context that led to the desire for healthcare reform in America? What are the provisions of the ACA, and what was the reasoning behind them? And what impact has the ACA had on our healthcare system, and what is the potential future of the program in our current political climate? The ACA is often heralded by politicians as the greatest reform of the U.S. healthcare system since the passage of Medicare and Medicaid by Lyndon Johnson in 1965. Yet, the conditions and circumstances that ultimately led to the development of the ACA go back much further than the establishment of these two programs. The original catalyst for the subsequent string of events that eventually led to the ACA can be traced back as far as 1942, during the presidency of Franklin Roosevelt in the middle of World War II. During the war, Roosevelt used executive action to establish the National War Labor Board, an organization whose primary mandate was to align the interests of the private economy with the greater war effort. One of the actions taken by the NWLB was to institute wage caps, an artificial ceiling on wage increases. They established a general wage freeze, meaning that employees were not allowed to increase wages for laborers unless granted an exception by the NWLB itself. But despite this artificial ceiling, employees still desired higher compensation, and employers were still willing to provide it for specialized labor in short supply. Consequently, a workaround to these regulations was incentivized. This workaround took the form of an increase in employers offering benefits as a way to supplement compensation without directly increasing wages. Since the NWLB did not include supplemental benefits in their wage cap regulations, the offer of additional benefits as an alternative to pay increases allowed the labor market to function closer to its natural condition. Additionally, in 1943, the IRS ruled that employer contributions to employee healthcare plans were tax-deductible as a business expense, further incentivizing this new model. Thus, the standard of employees acquiring health insurance from their employers as opposed to purchasing insurance in an open marketplace was established and has been maintained ever since. However, this standard of employer-provided healthcare coverage did not come without its drawbacks. For one, it left a significant gap in coverage for elderly Americans who were retired, did not have an employer to subsidize their health insurance costs, and could not afford options in the open marketplace. As individuals age, their need for and consumption of healthcare products increase as their health and well-being decline. Therefore, insurance companies are incentivized to price that greater consumption into the cost of their products for older demographics. This led to elderly individuals facing higher insurance costs at a time in their lives when their earning potential was lowest. To combat this problem, the Johnson administration implemented 2 new programs: Medicare and Medicaid. Medicare would offer elderly citizens an insurance plan at an artificially low rate, subsidized through a payroll tax on the younger working population. The idea was that costs for elderly and retired individuals could be kept lower by distributing them across a larger working population. Medicaid would utilize this same model, except providing subsidized insurance to extremely low-income individuals, regardless of age, as a means-tested program. The result of all these historical factors led to a unique situation. Under this framework, wealthy individuals, individuals with stable union employment, individuals in extreme poverty, and the elderly were all able to secure healthcare insurance without completely breaking their household budgets. However, this left one specific group, lower middle income working Americans, unable to purchase insurance at a cost conducive to maintaining their budget. Yet, with this specific group representing a relatively small constituency politically, the system was maintained essentially as is for the following 45 years. In the year 2000, the number of Americans with health insurance began a trend of precipitous decline, as traditional unionized manufacturing jobs were replaced with less specialized, less unionized service industry jobs. The number of workers receiving healthcare benefits from their employers declined in tandem. Then, with the onset of the 2008 economic crisis and the incredible spike in unemployment, even more Americans lost their insurance coverage alongside their employment. All these factors led to an increase in the specific group of lower middle-income Americans unable to afford insurance, giving this group greater political influence. This confluence of factors came to a head in 2008. During the election season, voters consistently ranked healthcare among their top 5 issues of concern, alongside the economy, terrorism, and education. With healthcare reform so high on the list of Americans' concerns, it was only a matter of time until Congress was forced to address this issue. Consequently, the conditions were met for a healthcare reform bill such as the ACA to find success in the legislature. Although today many Americans who identify as Republican or conservative heavily disapprove of Obamacare, sometimes lambasting the program as socialized medicine, the specific origins of the ACA can be traced directly to a program implemented by Mitt Romney, a Republican governor from the state of Massachusetts. The Massachusetts Healthcare Reform Law of 2006, often nicknamed Romneycare, essentially served as a framework for what would become Obamacare 4 years later. The two laws are virtually identical in design, goals, and implementation. In essence, Romneycare was an effort to secure health insurance coverage for every citizen of the Massachusetts Commonwealth through regulation of the insurance industry rather than socialization and government distribution of healthcare, as seen in countries like the United Kingdom and Canada. You see, even many proponents of free market capitalism recognize that there are some issues which prevent the healthcare marketplace from operating perfectly efficiently. Generally, economists understand that certain conditions must be met for a commodity market to reach equilibrium, and they call these conditions perfect competition. Healthcare, as a commodity market, fails to meet the conditions that allow for perfect competition, particularly regarding perfect information and homogeneous substitution. To illustrate this, we can compare the market conditions of two different commodities, fruit and healthcare services. In a market for fruit, consumers often have access to relatively perfect information and a vast array of homogeneous, substitutable products. When shopping for apples at the grocery store, a consumer is presented with hundreds of different apples, which they can immediately and quickly inspect for quality, and substitute with different brands or similar sweet fruits after considering this information. In a market for healthcare services, consumers often do not have or cannot ascertain the information necessary to understand the products and services they are comparing or considering to buy. Consider a hypothetical scenario where a customer is looking to purchase a product to help deal with the medical issue of hypertension. They are presented with a choice to purchase either lisinopril or Inestro, both at different price points. Unless the consumer has access to and the ability to understand information about how these products work and interact with their unique set of health conditions, they are unable to make an accurate assessment or economically efficient purchase. Another issue affecting healthcare service markets is the inelastic nature of the demand for certain healthcare products. To illustrate this problem, we can return to the previous comparison of fruit markets to healthcare markets. Let's consider someone shopping for apples at the grocery store once more. If this consumer finds that one day the price of apples has increased 100-fold from $1 to $100, they may likely replace their consumption of apples with some other similar substitute like oranges, pears, or mangoes. However, regarding healthcare, if the price of someone's life-sustaining, unsubstitutable cancer treatment were to increase 100-fold from $50 to $5,000, they would almost certainly continue to purchase the commodity rather than face certain death, even if it meant personal bankruptcy. It should be understood that the driving idea behind Romneycare, and subsequently Obamacare, was not to entirely socialize the healthcare services market, but rather to correct some of these market failures. The primary goal of the ACA was to decrease and ultimately eliminate the number of Americans who were priced out of the health insurance market by budgetary constraints, but were also not covered under the provisions of the Medicare or Medicaid social safety net programs. It aimed to achieve this through a combination of expanding government programs, regulating the insurance industry, and imposing legal mandates on individuals and certain businesses. Under the ACA, there is an expansion of government-subsidized health insurance programs like Medicaid. The ACA expanded Medicaid eligibility to all adults with incomes up to 138% of the federal poverty level in participating states. This addressed the issue of low-income individuals being unable to afford health care by increasing the number of citizens eligible for Medicaid. The ACA provided subsidies in the form of premium tax credits and cost-sharing reductions to help low- and middle-income individuals and families afford insurance purchased through the marketplaces. These subsidies were available to those with incomes between 100% and 400% of the federal poverty level. These subsidies helped those who were not poor enough to qualify for Medicaid afford insurance on the open market. The ACA restricted the ability of insurance companies to deny coverage to consumers with pre-existing conditions. This ensured that individuals who were previously priced out of the market due to pre-existing conditions could obtain coverage. To pay for the higher costs associated with these changes, the ACA implemented new taxes to generate revenue, as well as reductions in provider payments to reduce expenditures. These new taxes included an additional 0.9% Medicare payroll tax and a 3.8% tax on investment income for high-income earners. The ACA developed state-based and federal health insurance marketplaces where individuals and small businesses could compare and purchase insurance plans. These marketplaces offered standardized plans categorized by coverage levels: bronze, silver, gold, and platinum. This provided consumers with better information about products and organized a list of substitutions, attempting to address the perfect information problem. Likely the most controversial provision of the ACA was the individual mandate. The ACA mandated that everyone in the country must buy some form of insurance. This addressed the adverse selection problem by ensuring that young, healthy Americans who might not otherwise buy insurance would be part of the insurance risk pool, therefore subsidizing the cost of care for those who needed to consume more healthcare services. The ACA mandated that employers with 50 or more full-time employees must offer health insurance that meets a minimum standard of affordability, or else face a penalty. This provided more healthcare options to Americans who did not qualify for Medicare or Medicaid and reinforced the precedent set in 1942 when employers began providing benefits due to NWLB wage caps. These provisions collectively aimed to address various market failures in the healthcare system, improving access, affordability, and equity in healthcare coverage across the United States. The ACA has had both a profoundly real but variably perceived impact on the U.S. healthcare system since its passing in 2010. When asking the question, did Obamacare work? It is critical to clearly define what the goals of the legislation were, if those goals were met, and if the cost of achieving those goals was worth the value they provided to society. Proponents of the ACA will cite some key goals the program strives to achieve, and the data showing these goals were, in fact, met following the passage of the legislation. Above all else, the main goal of the ACA was to reduce the number of uninsured Americans, especially those who wanted insurance but were not covered by their employer, old enough for Medicare, poor enough for Medicaid, or wealthy enough to purchase it in the open marketplace. In this regard, the ACA was successful. Since the ACA's passing, more than 21 million people have enrolled in Medicaid due to the eligibility expansion, and 13.6 million have enrolled in health insurance plans through the ACA's marketplaces. Additionally, individuals with pre-existing conditions who were previously denied insurance were finally able to acquire affordable insurance due to regulations on insurance companies. While it is undeniable that the ACA achieved these goals, opponents of the program argue that the net cost to society outweighs the positive impact of more individuals acquiring healthcare insurance. For example, the individual mandate portion of the ACA was seen by many as a violation of personal freedom and individual liberty. If I don't want to buy health insurance, what right does the government have to force me to make this purchase? The general argument goes. This provision was so unpopular that it was eliminated altogether by President Donald Trump in 2019. However, since the regulations regarding pre-existing conditions were so popular, this element of the ACA was kept in place. But because the individual mandate was intended to be the cost control for the pre-existing condition regulations, it is now certain that the ACA will cause price increases as fewer young, healthy individuals participate in the risk pool to subsidize the cost for high-risk individuals. Additionally, opponents argue that the ACA created unintended consequences regarding employment. Due to the ACA mandating that large employers provide benefits for full-time employees, many employers were incentivized to offer less full-time employment altogether to avoid penalties under the mandate. At this point, it is likely that the ACA will be here to stay, regardless of whether your personal opinion on the legislation is positive or negative. Many provisions of the ACA have become too popular to see a political will for their removal. And the costs of the program are borne almost exclusively by minority voting populations, such as very wealthy individuals and large businesses. Furthermore, other costs of the program are hidden in complex layers of economic interactions that many voters will likely not correlate directly with the program itself, such as a decrease in full-time employment in favor of part-time employment and higher insurance costs or taxes for specific upper-middle income individuals. Reflecting on the question, did Obamacare work? Well, if you are a low-income individual who previously did not qualify for Medicaid, a 22-year-old who is still covered by their parents' insurance, or a patient with pre-existing conditions who now qualifies for insurance coverage, your answer is likely a resounding yes. However, if you are a mid-sized business owner, an upper-middle income earner who is not exorbitantly wealthy, or a philosophical libertarian, your answer is likely a resounding no. Well, what are your thoughts? Did Obamacare work? Let me know in the comments.